new chapter. This is the urinary system or the renal system. And we're gonna do this chapter, then we're gonna do, reproduction. And then when we get back, and then we have our, that's where we're heading. When we look at the urinary system, the kidneys primarily do most of the function of the urinary system. And essentially, what the kidneys are going to do is they're going to maintain the homeostatic levels and concentrations of our internal environment. And by our internal environment, we mean the plasma of the blood and the interstitial fluid. And of course, that then directly impacts the cells and their function. Just to emphasize the importance of this, 1/5 or 20% of the resting cardiac output goes to the two kidneys. So what we need is a really good interface between the blood and the kidney tubules, the nephrons. We're going to move some things out of the blood into the kidney tubules, into the nephrons. We're going to reclaim a bunch of that, and whatever we don't reclaim is going to be excreted into urine. This will enable us to maintain the proper concentrations of water, the proper amount of water in the body, the proper amount of electrolytes, our ions, and keep us in good balance. It will help us maintain our pH as well, along with the respiratory system. So this is the major function of the kidneys. We need to remove waste products as well. We need to remove foreign chemicals, as we see. So all that is the main function, but the kidneys do some other more minor functions, important but not the main thing. They make a little bit of glucose from non-carbohydrate sources, from amino acids and fatty acids. These are, this is gluconeogenesis, as you recall. We also produce some hormones and enzymes in the kidney. Erythropoietin, or EPO, is going to be produced and released from the kidneys, and that will increase our red blood cell count, our erythropoiesis, red blood cell production. In addition, if our blood pressure gets too low, the kidneys will produce an enzyme called renin, which will lead to the formation of the renin-angiotensin-aldosterone system and increase the reabsorption of sodium and chloride in water and get our blood pressure back up. We'll be talking about that more. Oh, on Monday when we get back from break, so a ways away, but we'll be coming back to that. And finally, the kidneys are going to be, along with the liver, responsible for doing the final metabolic step of activating vitamin D to its active form. So these are a number of functions that the kidneys do, but we'll spend most of our time on these upper functions. Before we get into the functions in detail, we have two kidneys. The left kidney is slightly higher in the body. Then we have two ureters that conduct urine from the kidneys to the urinary bladder. We have the urinary bladder to store the urine, and then we have the single urethra to take the urine out when it's convenient. When we look at the kidneys, we have a renal capsule. Renal means kidney, or associated with the kidneys. So we have a renal capsule surrounding the entire kidney. Then we have an outer cortex, and then a little bit deeper medulla with these sort of renal pyramids of the medulla. Right here, and here, and here, and here. deepest area, which is the pelvis. Within the cortex and part of the medulla, we have these tiny functional structures called the nephrons. They're very small, you have to have a microscope to see them. And we have about 1 million nephrons per kidney. And the nephrons do most of the work of the kidneys. Essentially what we're going to be doing is we're going to be moving some things out of the blood into the nephrons and reclaiming most of that. Most of what, when we move it from the blood into the nephron tubules, that's mostly done by filtration. A little bit by something called secretion, and we're going to go into that in a lot greater depth in just a minute here. Whatever we filter or secrete into the lumen of these nephrons, whatever we don't reabsorb, reclaim, gets excreted in the urine. We'll see that filtration is very non-specific. It's only based on size, whereas reabsorption can be specific. The initial part of the nephron is a combination of a renal corpuscle, and then you have the rest of it is a tubule. The interface between the blood and the nephron is primarily due to a unusually shaped capillary system called the glomerulus. Glomerulus is like a tufted ball of capillary. In addition to the glomerulus, we have another set of capillaries called the peritubular capillaries. Where the interface between the glomerulus and the nephron occurs, we can call that the Bowman's capsule or the urinary capsule. So we'll see some pictures of that. This is examples of nephrons. Here's a nephron. This is the renal corpuscle. It has the glomerulus right there, and then this would be the renal or urinary capsule. And then you would have the proximal convoluted tubule, the loop of Henle or nephron loop with the descending and the ascending limbs, and then the distal convoluted tubule, and then a number of nephrons can move fluid into the collecting ducts that we see here. Some of these nephrons are almost totally housed within the outermost layer, the cortex. These are the cortical nephrons. Some of them have the loop of Henle descending fairly deep into the medulla. These are the juxtaglomerular capillaries. Again, two sets of capillaries associated with the nephrons. The glomerular capillaries and the peritubular capillaries. Filtration takes place from the glomerular capillaries into the nephron lumen. The peritubular capillaries are involved in secretion and reabsorption. These are the glomerular capillaries. Here's our Bowman's capsule. Here's our proximal convoluted tubule, the loop, and then the distal convoluted tubule. Note the distal convoluted tubule comes in between two blood vessels right by this glomerulus area. These two blood vessels that we see in this diagram are both arterioles. So this is an unusual anatomical aspect. If we look at this, we bring blood to the glomerular capillary bed by an arteriole called the afferent arteriole. bringing blood to. But instead of, after the glomerular capillary, going to a venule or a vein, the blood drains from the glomerular capillary into a second arteriole called the efferent arteriole. So blood coming in to the glomerulus by the afferent arteriole and exiting the glomerulus by the efferent arteriole. After that, the efferent arteriole will form the peritubular capillaries, and then it'll go to the venules. There's an important anatomical difference between the afferent arteriole and the efferent arteriole, and that is the afferent arteriole is larger in diameter than the efferent arteriole. In other words, the arteriole bringing blood to the glomerulus is bigger than the arteriole taking blood away from the glomerulus. What that does is it increases the hydrostatic or blood pressure in the capillary. So capillary blood pressure is normally quite low, but in the glomerular capillaries, it's about 60 millimeters of mercury, much higher than in most capillaries. When we see this structure, this is the beginning part of the nephron. Here's our Bowman's capsule and our urinary space here, and then this is the start of the proximal convoluted tubule. We have about 1 million of these units in each kidney. So this is just one. Between the afferent arteriole and the efferent arteriole, we have the distal convoluted tubule coming in. If we go back one, here's the distal convoluted tubule coming in between the afferent and efferent arterioles. And we're going to have what's called the juxtaglomerular apparatus right in there. And that's going to be something that we're going to look at again just in a little bit. Here's the name, juxtaglomerular, right there. Movement of substances and fluid out of the glomerular capillaries into this Bowman space or urinary space that we see right here is called filtration. That's how most things get from the blood into the lumen of the nephron. This filtration barrier is made up of some podocytes. A podocyte is a foot cell, you know, like a podiatrist deals with the feet. So here's the name of the cell, a podocyte. Somebody named it a podocyte. And these podocytes have these little processes called pedicels. And these form filtration slits. There's also a little structure called the basement membrane. If we blow this up really big in an electron micrograph, this is what it looks like. You have these little filtration slits. Whatever is going to filter from the glomerular blood into the nephron has to fit. It has to get through that basement membrane, and it has to fit through these little gaps. The easiest way to remember this is to know what isn't filtered from the blood. What isn't filtered from the blood are the formed elements: red blood cells, white blood cells, and platelets. If we see blood in the urine, that means we have something wrong. Something is getting filtered that's not supposed to, like red blood cells. Normally, we do not filter red blood cells, white blood cells, and platelets because they're too big. In addition to that, we filter very few proteins. Most proteins are too big to be filtered. We might have trace amounts of protein in our urine, but essentially we don't filter proteins as well. So if we remember that, we don't filter red blood cells, white blood cells, platelets, or proteins. Everything else gets filtered. Okay? Water, ions, glucose, amino acids, everything else gets filtered. If it's small enough, it gets filtered. If you have a coffee filter, and you put some coffee stuff in there and some water, and it filters through, it's a size, right? The water goes through, some of the tasty stuff and the coffee stuff goes through, and then the grounds, you throw them away, and they don't get filtered. Well, it's the same idea here. Now, if we look at this electron micrograph carefully, do you see, okay, this is the blood, this is capillary, this is going into the nephron, here's our filtration barrier. Do you see this structure right here? That's a little piece of a red blood cell. That's one red blood cell. Is that guy gonna fit through here? No, it's way too big. So red blood cells don't fit through, platelets don't fit through, white blood cells don't fit through, and most essentially proteins don't fit through. So filtration is non-specific. It's only based on size. Everything else gets filtered. Now we're going to take a sidestep and look at a little regulation, and then we'll go back to filtration and all of that. The juxtaglomerular apparatus, where is it? It's right here. What does it do? Well, some of the cells in the juxtaglomerular apparatus are going to sense blood pressure. They're mechanoreceptors. These are located, associated right on the edge of the afferent arteriole. Here they are in our diagram right there. These JG or juxtaglomerular cells, they can sense blood pressure. And if our blood pressure is too low, they will release renin, which will stimulate the renin-angiotensin-aldosterone system, which will cause us to reabsorb more sodium, more chloride, and more water, and raise our blood pressure back up. We have some other cells, the cells of the macula densa. These are associated with the distal convoluted tubule. Here they are here. Here's macula densa, and here they are in the distal convoluted tubule. These are more chemoreceptors. They're going to sense the concentrations of sodium and chloride. Again, if our sodium and chloride levels are off, we will stimulate hormones to get them back, like aldosterone, to get them back into balance. Here we look at it. This is our glomerulus. Here's our afferent arteriole, bringing blood into the glomerulus. Here's the efferent arteriole taking it away. Notice that the afferent arteriole is larger in diameter than the exiting efferent arteriole. Here's the distal convoluted tubule coming by. Here's our juxtaglomerular cells, and here is our macula densa cells. Okay. We also have the podocytes here, and so if we're going to filter, we filter from the glomerulus into this urinary space or Bowman space and on into the proximal convoluted tubule. Filtration, of course, is aided greatly by the fact that we have a relatively high pressure inside the glomerulus, about 60 millimeters. There's one other type of cell in the area called a mesangial cell. These also help regulate blood flow through the glomerulus. They engulf any macromolecules that get hung up in that filtration barrier, and they remove them. It's like if you have a grape and it's raining and a bunch of leaves get caught in the grape, clogs it up. These mesangial cells grab the leaves out of the grape, essentially. They grab macromolecules that are too big to filter, but they get caught up in that, and then they grab them and they move them, they get them out of there. This is the name right down here, mesangial cell. We briefly mentioned that we have two types of nephrons. The cortical nephrons are the most common, about 85%. These have very little of the nephron in the medulla. They're almost all in the cortex. This is an example of a cortical nephron. Notice only a very small part is down in the medulla. Most of it's in the cortex. On the other hand, we also have the juxtaglomerular nephrons, about 15% of the total. These have their loops, the nephron loops or loop of Henle, descending down into the medulla. The juxtaglomerular nephrons are going to be responsible for concentrating urine. On that audio lecture for Friday, we're going to go into quite a bit of depth on how we concentrate the urine. And these juxtamedullary nephrons are the ones that predominantly do that. Here in this diagram, you can not only see the glomerular capillaries, but now you see the peritubular capillaries. They have a good name. They're around the tubules of the nephron. So these are the peritubular capillaries. So again, the blood coming in to the glomerulus is brought in by the afferent arteriole. Then it goes out through an efferent arteriole, and then it goes to these peritubular capillaries, and then it goes to venosa veins. If we move substances into the nephron from the glomerulus, we call it filtration. If we move substances into the nephron from the peritubular capillaries, we call it secretion. Those are the two ways that things can move into the lumen of the nephron. And by far the more common is filtration. But we do have some important things, items that are secreted. If we grab it back out of the nephron tubule into the peritubular capillaries, we call that reabsorption. Whatever is filtered and or secreted and it is not reabsorbed is excreted in the urine. Let's say that again. Whatever is either filtered and or secreted and is not reabsorbed will be excreted in the urine. This gives us a little more simplistic diagram. Here's the glomerular capillary. If you're moving substances from the glomerular capillary into that nephron at that site, we call that filtration. If you move it in from the peritubular capillaries into the lumen of the nephron, we call that secretion. If we reclaim it back from the tubule lumen into the peritubular capillaries in this direction, we call that reabsorption. If it goes out in the urine, we call that excretion. So again, whatever is filtered and or secreted and not reabsorbed is excreted. Another way of saying that, whatever is excreted equals the amount filtered plus the amount secreted minus the amount reabsorbed. Filtration, secretion, reabsorption. Some substances are filtered, as you see here in substance X, and secreted and not reabsorbed. Our example, substance X is being filtered and secreted but not reabsorbed. Substance Y is filtered and not secreted and partially reabsorbed and partially excreted. Substance Z is freely filtered and 100% reabsorbed and not secreted. Substance Z, we'll find out, an example of substance Z is glucose. Glucose is freely filtered, not secreted, and 100% reabsorbed under normal circumstances. What are some of the forces affecting filtration? The force favoring filtration is the hydrostatic or capillary blood pressure. And at resting conditions, this is usually about 60 millimeters of mercury, as we see here. We have two forces opposing filtration. One is the fluid pressure in this urinary or Bowman space. That's usually around 15 millimeters of mercury. And then the osmotic force, because you have the proteins that remain in the plasma, the solutes. So this backward osmotic or oncotic force is usually about 29. When we sum all these together, the forces favoring filtration is about 16 millimeters of mercury. We can change this filtration rate, as we'll see. Before we get into looking at how to change the filtration rate, we'll give you some rather staggering numbers that will remind you of a few times. We generally filter about 180 liters of fluid and dissolved solutes every 24 hours. 180 liters. Is this a liter? 1.5 maybe? Maybe 1.5, so this is too big, but if we imagine a liter, we line up 180 of those. That's how much we filter in 24 hours. When's the last time you peed out 180 liters in 24 hours? We'd be dead, wouldn't we? Many times over. Our total blood volume is what? About 5 liters. We filter 180 liters in 24 hours, but we reabsorb all but about 1.5 liters, or 1 liter, or 1.8 liters. We reabsorb almost all the water that we filter. Our urine output is usually about 1.5 liters. Reabsorption is specific though. We can increase reabsorption or decrease reabsorption, depending on the needs of the body. So filtration is non-specific, size dependent, but reabsorption is more precise, more specific. Now, how do we change our GFR? What's our GFR? Glomerular filtration rate. Well, we can do it by changing the diameter of our afferent and efferent arterioles. If we constrict our afferent arteriole, we're allowing less blood to come in. That will mean less volume, less pressure. That will decrease our glomerular filtration rate. If, on the other hand, instead of constricting the afferent arteriole, we dilate our efferent arteriole, we allow more blood to go out more easily of the glomerulus. That would also decrease our glomerular filtration rate. On the other hand, if we want to increase our glomerular filtration rate, we could constrict even further the efferent arteriole, or we could dilate the afferent arteriole. So by simply changing the diameter of the arteriole bringing blood into the glomerulus and the arteriole taking blood away from the glomerulus, we can change the pressure in the glomerulus and change the filtration rate. The kidney auto-regulates. What that means is it's going to get its blood, if at all possible. And so if our blood pressure changes, the kidneys will auto-regulate to try to maintain the glomerular filtration rate as long as they can. And that just emphasizes how important their function is. Because if we don't perfuse the kidneys enough, we go into renal failure, everything goes off. Our fluid, our ions, everything, and then it cascades down and we die. A lot of patients on their death certificate says renal failure. Well, they had some other issue in finding their kidneys failed, and that threw everything in and else in the kidney into problem. But the kidneys try very hard to maintain their perfusion. That's their blood flow. Because their role in maintaining homeostasis is so important. Now this is how much water do we filter in a day? About 180 liters. How much do we excrete? About 1.5 liters. This is 1.8 to make the math easy. So we reabsorb about 99% of it. Sodium, we filter, we excrete just a small amount. We reabsorb most of it. Glucose we freely filter, but normally we don't excrete any, do we? We reabsorb it all. If we find glucose in the urine, that's not good, right? You might have diabetes or something. We can overwhelm this, as we talked about in the endocrine system, if we have hyperglycemia and we filter more glucose and we don't have enough carriers to reabsorb all the glucose fast enough, then glucose starts appearing in the urine. But normally, if our blood glucose is within normal limits, we freely filter the glucose, it's small enough, but we reabsorb it all. And none appears in the urine. Urea is a little bit of a metabolite from proteins, and we filter and excrete, but we do reabsorb part of it, but eventually it gets excreted. What do we want to chat about before we go to the next? Feel okay about this so far, or clarify anything, or just chat about something? No stress. You feel all right? All right, well, in our audio lecture on Friday, we're going to describe reabsorption in a lot more detail, how things get reabsorbed. Before we get to that aspect, let's talk about a concept called renal clearance. The reason we want to talk about this concept now, renal clearance, is because by using this concept, we can calculate the glomerular filtration rate. We often, if you were going to deal with patients, need to be able to calculate or estimate at least the patient's glomerular filtration rate. So how do we do that? Well, we use this concept of renal plasma clearance. Now, one thing is a little bit non-intuitive here. When we talk about plasma clearance, we're saying this volume of plasma is cleared of a particular substance. That means it's removed from the plasma. Cleared means, okay, we're taking it out. And so that's what we're looking at. And that sounds a little bit odd, an odd way to say things, but that's the way it is. So how do we do this? We have an equation.
renal plasma clearance of a substance per minute is given by the equation, the concentration of the substance in the urine multiplied times the volume of the urine divided by the concentration of the substance in the plasma. Now, we can calculate all of these factors, all these variables. We can calculate, we can have the patient peeing into a thing, and when we calculate the concentration of the substance in that container, we can calculate the urine volume, how much is in there, and we can do a blood draw, and we can find the concentration of the substance in the blood. So we can find all these things. Here's some numbers we can put in. Here's the clearance of the substance. In this substance, in this example, we're using a substance called inulin. Notice that inulin is not insulin. It just sounds close. Inulin is not made by the body. It's a synthetic substance that's not made by the body. But you can inject inulin in a patient's IV or something like that. The advantage of inulin is inulin gets freely filtered, it doesn't get secreted, and it doesn't get reabsorbed. So if we look at the clearance of inulin, we are calculating the glomerular filtration rate. Because it's only filtered, it's not secreted, it's not reabsorbed. So a classic example is when we give inulin, we might have over time a concentration of 4 milligrams per liter of inulin and 30 milligrams. So this is how much is in the urine, 30 milligrams per hour. This is the volume of the urine, 1 liter per hour. And this is the plasma concentration, 4 milligrams per liter. We put all of those into our equation and we can calculate it. Here we calculate it as 7.5 liters per hour. By the way, what's 7.5 liters per hour? If we wanted to convert that per day, we could multiply that by 24 hours. What would we come up with? All the mathematicians. I don't know if I can do that in my head. Can you? You can always use a calculator. How much? 24 times 7.5 is how much? 180. I think we've heard that somewhere before. That's our glomerular filtration rate per day, right? So 7.5 liters per hour is the same as saying 180 liters per day. That's our glomerular filtration rate. We just calculated it by doing the plasma clearance per inulin. Is that right? So we calculated it with a relatively non-invasive procedure. But you might say, well, I want to be even less invasive. I don't want to inject inulin into the patient. Isn't there a way I could get pretty close without injecting inulin? Yes. We can use the plasma clearance of creatinine. Creatinine is a metabolite, and creatinine gets freely filtered, it doesn't get reabsorbed, but a smidge of it gets secreted. So it's not going to be quite 100% accurate, but it's going to get close. We can approximate by simply doing a plasma concentration of creatinine, a urine concentration of creatinine, and finding the urine volume, and that will give us a pretty good estimate of the glomerular filtration rate, and we don't have to inject the person with inulin. So that's often when it's done. But if you really want a precise glomerular filtration rate, you could always inject inulin. It doesn't hurt the person, but you can get a precise value that way. All right, our major last concept for today is control of micturition or urination. The urinary bladder is a storage form for the urine until it's convenient to get rid of it. We don't absorb anything from the urinary bladder. It just sits there until we can excrete it. To exit the urinary bladder, we have two sphincters in series, just like the anal sphincters. We have an internal urethral sphincter and an external urethral sphincter. The internal urethral sphincter comes first. It's just a pressure valve. When the pressure in the urinary bladder gets great enough, it opens. It's controlled involuntarily. The external urethral sphincter is controlled voluntarily. And that's what we learn to say, okay, we're going to relax this when we want to pee, okay? So we relax it. The internal urethral sphincter is involuntary and it has smooth muscle. The external urethral sphincter is voluntarily controlled and it has skeletal muscle. So we need both to relax in order to initiate urination. The sympathetic system tries to hold the sphincters shut, the internal. The parasympathetic causes it to open. We also have the somatic nervous system, non-autonomic, which helps control the external urethral sphincter. So it's a combination of these. Within the wall of the urinary bladder, we have some smooth muscle called detrusor muscle, and the parasympathetic system causes it to contract during urination to push the urine out. With that background, let's do an overview with a little animation here.
The micturition reflex involves impulses traveling from the urinary bladder to the sacral region of the spinal cord, and from the sacral region of the spinal cord back to the bladder.
Remember, the sacral region of the spinal cord is craniosacral, is parasympathetic. Okay, we'll cut it down. Yeah. Maybe it's a test on urination and then it's out. Let's lower the volume a bit. Don't freak them out over there next door. Thanks for telling me.
It is coordinated by neurons in the spinal cord and can be influenced by signals from the brain. When the urinary bladder becomes stretched, there is an increase in the frequency of action potentials carried from the bladder wall to the sacral region of the spinal cord. In response, parasympathetic neurons from the spinal cord to the bladder are activated, and this causes the smooth muscle on the bladder wall to contract. The sensory signals to the sacral region of the spinal cord also stimulate ascending pathways to the pons and cerebrum, which results in a conscious desire to urinate. If urination is not convenient at the time, the brain sends impulses down the spinal cord to inhibit the micturition reflex. Impulses carried via somatic motor neurons keep the external urinary sphincter contracted, which also prevents urination. When urination is desired, signals from the brain stimulate the micturition reflex. The brain also decreases action potentials in the somatic motor neurons to relax the external urinary sphincter.
This is sort of a review table for that. The detrusor muscle, parasympathetic, causes contraction. that's inhibited during filling and stimulating during micturition. The internal urethral sphincter, which is smooth muscle and involuntary. Sympathetic causes contraction. That holds it so you're not peeing when you're running through your life. And the external urethral sphincter, skeletal muscle, somatic, causes contraction, and then you can inhibit it during micturition. So it's but a lot of factors are involved in it. Essentially, we want to relax this internal and external sphincter, and we want to contract the detrusor muscle during urination. And we want to do the opposite when we are not doing urination. Unfortunately, especially as we age, there can be incontinence where there's urination when it's not desired, or leakiness. Sometimes you can have stress incontinence. This could even be when you're younger, when you're sneezing or coughing or exercising or laughing or something. You pee your pants a little bit, okay, well that's just a little, right? There's also urge incontinence that just, you always feel like you have to pee. Just because of anatomy, incontinence is more common in women, but of course it occurs in both. Medications such as estrogen replacement therapy after menopause can improve vaginal tone, which can help relieve incontinence. Sometimes you might even have to have surgery, although this is not commonly done, to improve vaginal support of the bladder and urethra. If you have an irritation such as a bacterial infection that can cause urge incontinence, you can treat it with certain drugs. Flomax is what this is essentially. This basically blocks the parasympathetic action of the detrusor muscle, but it can have side effects. Okay, so on our audio lecture Friday, it's going to pick up here, and it's going to go through a little bit of filtration, but mostly reabsorption of things. Then it's going to talk quite a bit about how we build up a concentration gradient with a countercurrent multiplier system in the medullary space. And there's a video that goes along with that, and I put that in that same file that you can watch. So go over all that.